Hello and welcome to our new GameMed English educational video. My name is Margot and today we are going to cover the topic of mental health and the primary assessment in it. Let's get it started. According to World Health Organization, mental health is considered as a state of well-being in which the individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community, rather than the absence of mental illnesses as it was previously. There are many warning signs of mental illnesses. These include eating or sleeping disorder, avoiding people and usual activities, having low or no energy, feeling numb or like nothing matters, having unexplained aches or pains, feeling helpless and hopeless, smoking, drinking, using drugs more than usual, feeling unusually confused, forgetful, on edge, angry, upset, worried, or scared, yelling or fighting with family members and friends, experiencing severe mood swings throughout the day, having persistent thoughts and memories, hearing voices or beliefs, things that are not true, thinking of harming yourself and the other people, inability to perform daily tasks. All these lead us to the next step, to the mental health assessment. Basic mental state examination consists of 10 steps. These include appearance, behavior, speech, mood, affect, thoughts, perceptions, cognition, insight, and risk assessment. Let's take a look at each of them and see how it works on practice. While assessing the appearance, we look for the patient's demographics. The gesture as an integral gender, religion, ethnicity, etc. We also take a look at the type of clothing that the patient chooses, because many of them may be for the season and weather disorders, such as does it reflect their mental health? Then we take a look at the clothes are clean and or chunky. So we check if the person is capable of maintaining eye contact, comfortable for the person. Do they have any kinds of emblems or logos, etc.? Is it engaged? Then we take a look at the posture. Is it closed or open, especially during the talk? The gait, if it's hesitant or propulsive. Then we take a look at the grooming and self-care, hygiene, the psychomotor activity. We take a look at the way that the person has his slower haircut. And take a look at the eyebrows, at the state of the skin, activities during the talk. Check physical health. The next step is checking disinhibited behavior, painful symptoms, any kinds of biological symptoms, something that may cause the loss of energy, motor. We also take a look at the alcohol and substances abuse. Our next step is checking their engagement. If so, which ones, the foundation of this part of assessment. It is important to know assessing the appearance, we look for the patient's demographics. This includes age, gender, religion, more interesting topics for the person or less. The type of clothing that the patient chooses, is it appropriate for the season and weather? Does it reflect their mental health levels of arousal? If the clothes are clean or chunky, are the clothes the symptoms of some comfortable for the person? Do they have any kinds of emblems or logos, etc.? Our next step is behavior assessment. Here we look at the gesture as an integral feature of nonverbal communication. We also take a look at the mannerisms, because many of them may be symptoms of psychiatric disorders such as compulsions and rituals. Then we take a look at the eye contact and body language. So we check if the person is capable of maintaining eye contact and how the posture looks like. Is it open? Is it closed? Is it engaged? Or then we also take a look at the facial expressions, especially during the talk. Are they expressive, relaxed? Maybe the person is smiling, laughing, happy, anxious. We also check the psychomotor activity. Does the person talk faster or maybe even slower? and what are the motor activities during the talk. The next step is checking disinhibited behavior. It is a disregard of social conventions that affects motor, instinctual aspects, and perceptual aspects. Our next step is checking their engagement. It is the foundation of this part of assessment. It is important to note if the report is easy to establish or difficult. Are there some more interesting topics for the person or less? Maybe sometimes the person would space out, etc. And the last but not the least are the levels of arousal and abnormal movements. When we talk about abnormal movements, we think of the symptoms of some organic conditions such as dystonia or tics, akathisia, etc. Our next step is checking the speed. Usually, we don't ask the direct questions, but rather observe and listen to the patients talking during answering the other questions. We need to note any paralinguistic features such as volume, rhythm, prosody, articulation, quantity, rate, latency of speech, fluency and rhythm, root, etc. Then we get to know about the mood. Here we think of two main aspects, objective and subjective mood. Objective mood is something that we observe as healthcare professionals and assess. Subjective is the one that is described by the individual himself or herself. So that's basically answering the question, how are you feeling? What kind of mood do you have right now? Our next level of assessment includes affect. Affect is kind of an emotion, but it's the one that is expressed immediately after asking the question. So we check the intensity of affect. Is it flat or blunted? Its quality, its fluctuation. Is it labile? Can it be easily altered between the states? Its range. Is it restricted or expansive? And congruence. The sixth step is assessing thoughts. Here we take a look at the stream. It's the amount and speed of thoughts. Form of thought, it's the way in which the thoughts are linked together and processed. The content of thoughts, what kinds of ideas does the person present? And their possession, that's the belief that others can manipulate the thought. While assessing perception, at the very beginning we look at the perception complexity. Is it elementary or complex? So the person understands somebody's voices and language, music, faces, scenes, and the perception modality. So does the person fully understand everything from the auditory, visual, olfactory, gustatory, and somatic systems of perception? We also ask whether the individual's perceptions changed recently. Are they experiencing some kinds of delusions, illusions, hallucinations, or other abnormalities? Afterwards, we ask for the encephalitis. Does the patient have acute psychotic symptoms? Have they recently had a tumor? Have they experienced adverse effects of antipsychotics, etc.? Afterwards, we ask for reflex hallucinations. Then about the concentration. So if the person has the problems with concentrating on some specific stimuli while reading the newspapers, watching TV, and being able to pay attention to something concrete during the work. Afterwards, we ask for the experiences. How does the individual respond or describe the experience? Has the environment changed for the person during the last few years or months? Afterwards, we ask for pseudo-hallucinations. These are similar to hallucinations, but they are a bit shorter and are found in psychotic patients. Afterwards, we are looking for the hallucinations themselves. These include tactile, auditory, visual, gustatory, and olfactory hallucinations. Afterwards, we ask if the patient has ipseity disturbance. This is a disruption or diminishing of a person's sense of self. Afterwards, we are assessing organic states, some organic mental disorders, or sometimes neurological illnesses. Then we pay attention to negative symptoms. These include 5 A's: affect, apathy, elogia, evaluation, and anhedonia, and use the scales for this assessment. And the last but not the least is sensory distortion and deception. How does the person perceive objects? Is it in a distorted way? Are they capable to respond to stimuli, etc.? Next, we take a look at the cognition. It's the awareness of him or herself, of the environment. And here, at first, we pay attention to the orientation of the patient in time and space, also in his or her person, of course. Next step is clouding of consciousness. It's a state of drowsiness, some problems with the thinking and concentrations. Next, we pay attention to stupor. Is it present? It's a state where the individual is mute, immobile, or unresponsive for some period of time. Then we assess immediate, recent, and long-term memory. The next step is visuospatial functioning. So here we are looking for the ability to identify visual and spatial relationships between the objects. Then we assess the insight. It's the patient's understanding of his or her mental illness. There are 6 levels of insight. The first one is a complete denial of illness. The second one is slight awareness of being sick and needing help, but denying at the same time. The third step is awareness of being sick, but blaming it on others, on external factors like physical illness. The fourth step is awareness that illness is caused by something unknown. Fifth level includes intellectual insight. So the patient is aware that there is a mental illness and it doesn't apply this he or she doesn't apply this knowledge to the future experiences. And the sixth level is emotional insight. It's emotional awareness into the feelings and illness and ability to modify behavior accordingly. The next step is assessing the risk factors, and the number of these risk factors is huge. So we'll try to group them into 5 small groups and try to cover them briefly. So the first group is health conditions. This includes something that can't be changed, for example, excessive substance use, low birth weight, neurochemical imbalance of the patients, and medical illnesses, chronic disabilities, etc. The next one is other individual factors. Here we put the individual experiences of the person, such as personal loss, family conflict, trauma, early pregnancies, communication deviances, stressful life events, etc. The next 2 groups are childhood factors and environmental factors. Childhood factors would include child abuse and neglect, parental mental illness and substance abuse, some complications during the childbirth, some elder abuse, while environmental factors would include poverty, poor social circumstances, isolation and alienation, some displacements, etc. The last but not the least is the social group of factors, such as work stress, war, attention deficits, urbanization, peer rejection, social disadvantage, and so on. The patient then undergoes many other steps, but in case if he or she is completely healthy, nothing matters, they may implement some protective strategies into their lives, such as self-care about the body, limiting alcohol, caffeine, sugar, and substances consumption, keeping a diary to monitor their mood and behaviors, stress control strategies, some psychological education, especially in the school and universities, and social and psychological services integrated into the educational and work systems. Thanks for watching this video. If you enjoyed it, don't forget to subscribe to our channel, leave us your feedback through the likes, dislikes, or comments, and subscribe to our other social networks. We have accounts in Instagram and Telegram, where we post some interesting facts, vocabulary that is useful, and different kinds of announcements about our upcoming videos and meetings. See you soon on Monday. Bye bye.